The following Ardelyx podcast is intended for informational and educational purposes only and cannot be considered as medical advice. Please speak to a healthcare professional before making any treatment decisions.
Hello, everyone. Welcome to today's podcast. I'm Andrea Shin, a gastroenterologist at UCLA, and I'm here with my co-host, Johannah Ruddy. Today, we'll be talking about Beyond the Gut, cultural nuances in IBS-C management. And I'm happy to share that we have a guest with us today, Dr. Rosie Frazier. Dr. Frazier is a board-certified gastroenterologist with a special interest in gastrointestinal motility and disorders of gut-brain interaction. She's an assistant professor of medicine at Mayo Clinic, School of Medicine, and she completed her training in internal medicine and gastroenterology at the University of Texas Health Science Center, San Antonio. She strives to develop meaningful physician-patient relationships and individualized care based on the patient's goals and values. In addition to her clinical activities, Dr. Frazier is active in research and medical education, and we are absolutely delighted to have her here with us today. Welcome.
Thank you, Dr. Shin. Thank you, Johannah, for this invitation. I'm very excited to have this conversation here, a very important conversation, very relevant for our patients with irritable bowel syndrome.
Yeah, absolutely. We're thrilled that you're here, Rosie. And I think, before we get into our conversation around, cultural considerations for our patients who are struggling to find good care for their IBS, I'd love for Andrea to just reshare and just kind of get us back up to speed on what IBS is, how it's diagnosed in the clinical encounter. And then from there, we can talk about, how these symptoms can present or be explained differently based on a person's cultural background. And I'm excited to talk about this. So Andrea, can you set the stage for us and remind us what IBS is?
I'm really glad that we're having this conversation today because it's so relevant to irritable bowel syndrome. So for people who are just joining us today, and I'm sure many who have already tuned in for future sessions are familiar with this, but irritable bowel syndrome is a very common GI disorder. It's probably amongst one of the most common disorders that's seen by gastroenterologists. And it is defined according to very well-established clinical symptoms, pain and bowel dysfunction. IBS-C in particular is irritable bowel syndrome with symptoms of constipation. And the reason I think that today's conversation is so relevant is that in order for us to be able to make a diagnosis and to help patients that come into our clinic, we have to be able to get meaningful history and understand the symptoms that a person has been living with. And again, we have to kind of go back to symptom-based criteria. And so that communication aspect of it is so important for patients and providers. So today, I think, talking a little bit about that from a culturally competent perspective will be really insightful.
At Ardelyx, we're dedicated to improving the lives of patients by discovering, developing, and commercializing first-in-class medicines that advance care to patients with unmet medical needs. Learn more about us at ardelyx.com.
Because it is diagnosed by symptom criteria that is addressing, the symptoms as you mentioned, language plays a huge role here, right? So Rosie, I'd love to have you start by talking about, some of these medical terms like constipation or abdominal bloating or pain, bowel movements. All of those can be really tricky for patients where English is not their first language when they're trying to describe their symptoms to their gastroenterologist. So can you discuss that and how some of these terms don't translate accurately to English?
Absolutely. I think it is very important that we address that because, as Dr. Shin mentioned, irritable bowel syndrome is a clinical diagnosis, and we have to interview this patient. And however, how they express these symptoms, how they feel these symptoms, how they report these symptoms, is influenced by their cultural background, by their beliefs, their language. And we have to take in consideration that in the United States right now, approximately 25 million of people are not fluent in English, or like English is not their first language. And not only that, even people who are proficient in language, they may have grown up in a house where there's a lot of other cultural background. So to give you some examples, we always think about bloating, right? And bloating is one of the most common symptoms that we see in our clinical practice. However, in other languages, bloating cannot be translated in Spanish. There is not a word for bloating. And sometimes what people will use, and especially people with limited English, they will use inflammation, right? Or
Right.
discomfort or empathy. So they are things that even for someone who is fluent in Spanish and English, it will be very difficult to translate or understand what does it means. So I think we have to be very, very detail oriented when the patients are giving us these terms, and also try to understand what do they mean with that. Another example I like to always give is when somebody say, I have abdominal discomfort. What does abdominal discomfort mean? It can mean many things, and there have been studies that show that, especially among different cultural background patients. For some people, abdominal discomfort could be abdominal pain just in a mild severity. For other people, abdominal discomfort could be just fullness, postprandial fullness, and for other people that may be bloating. So we really have to ask our patient, can you explain me a little bit more about it? What do you mean with that? And have an understanding that what for we assume it means may not be the case for the patient, and that in their case they may have a limited vocabulary to how to explain, or a different vocabulary of how they will explain their symptoms. Symptoms that by itself they are challenging even for somebody who speaks very well English, or we that has grown up in the United States. They can be very challenging because there's a little bit of shame, some embarrassment, something they will not present, or that in society is very well accepted as an illness, where people have a little bit of bias towards this, or a little bit of shame. So it is challenging, and communication is centered to make this diagnosis and to treat. So we really have to build a good patient-physician relationship.
How important is nonverbal communication with your patients in these situations, particularly for patients who, English is their second language and they may be interpreting your verbal communication differently than patients where English is their first language? So how important is nonverbal? Those nonverbal cues, body language, all of those sorts of things in really helping them feel comfort and validation and support in your communication.
Absolutely. I think nonverbal cues are very important, and especially patients with limited English, or patients with a different cultural background, or in any patient-physician interaction. I think nonverbal cues is a two ways where I always try, as the patient comes, try to start understanding, and if they are coming with a family member or a friend, try to see those nonverbal cues. But at the same time, I have to be um, very attentive of my nonverbal cues, because some
Yeah.
of these things, in many cultures, looking eye to the eyes to a person may be disrespectful. With in other cultures, it may be that they feel that you are listening to them when you look at their eyes. So it is very important to try to adapt, and always have in our mind, one size doesn't fit all. We have to adapt to every patient. And in order to adapt, we have to be attentive, and we have to be attentive with no verbal cues. And also something that I also like to use a lot is with these patients' images,
Yeah.
diagrams, algorithms. I have
I
found
was
that
going to
that's,
ask you about that. Yes.
yeah.
Yeah.
Yeah, I have found that very helpful in my practice, and
Mm,
especially when I'm trying to understand the symptoms. I have pictures. I have a folder that I carry with pictures about bloating, distension. I also have pictures. I think that we all know irritable bowel syndrome pathophysiology is very complex, and we know there's no only one element, but there are many that are involved. However, that's our understanding as healthcare providers. However, for patients, many of our patients think that when we give them a diagnosis of irritable bowel syndrome, they can feel dismissed. They can feel that that is something only on their mind. So I also like to have this diagram that shows all the things that we have recognized that are involved in the pathophysiology. And as we know, it's a long list. And that
right.
really helped them, help me communicate with these patients saying, it's not all on your mind. There's a lot of things going on. And that's why you are having these symptoms, as you can see in this picture, in this diagram. And we just need a better understanding and the treatment. I hope we had a cure, but we are still understanding all this.
Yeah.
And also when patients come with internet things about, well, I have heard this is the problem with IBS. I say, you are absolutely right. This is one of the problems. You can see here in my list. That's one of the problems, but that's not all. It's more complex than
Right.
that. So I
Yeah.
think that really helped.
No, that's great. I think I love visual aids. I think many people like myself are visual learners, and the more you can differentiate your education, whether it's giving them handouts or visual aids, pictures, etc., to really help them understand no matter what their learning type is. I think that's really, really important. Andrea, you have a really culturally diverse community where you serve as well. What's how do you kind of, before you're going in to see a new patient, for example, how are you kind of getting yourself prepared if that patient is needing extra supports with language or cultural sensitivities or things like that, in kind of preparing for that visit?
Yeah, I think that's probably a step that we have to really prepare for, especially if we are meeting with patients and people who are from different backgrounds. I'm fortunate that we have a pretty wide range of staff on our team who are always available to kind of help out and facilitate and assist if we need more help in that space.
Yeah.
I do, and I'm sure most providers do. I do always kind of do a brief check through the medical records just to see
Right.
if I can gather any sort of like important social context. And if there are language barriers, obviously we make sure to have a certified translator, although that's an imperfect solution. And oftentimes I am fortunate when patients bring in family members with them who might be able to help facilitate a conversation as well.
Yeah.
And sometimes, family members can be helpful to assist with the communication, but sometimes even just adding in some additional information that maybe
Right.
the patient themselves may be struggling to express at the time. So those are kind of all, I lean on multiple people to
Sure.
help process from the patient side and also from our team side. But it can definitely be challenging, especially if you've got someone from a totally different background and maybe you don't have much familiarity.
Yeah, absolutely. So that kind of brings us to, the idea around we all have our different family histories and cultures, whether it's, the way we were raised, our religion, that influences how we see our illness or our decisions around treating our illness. But I think the biggest thing where this comes into play is around dietary, kind of cultural celebrations, or food is so important to so many of us. And in our celebrations with family or friends or holidays, food plays a central role, as we know. And Andrea and I have talked in previous episode with Kate Scarlatta, our GI dietitian friend, about the role of food and dietary therapies in IBS. But Rosie, from your, the work that you do in this area, and I know you do a lot of work with dietitians in your at Mayo as well. How do you discuss dietary recommendations that may be conflicting with cultural practices with your patients? A lot of patients culturally eat certain foods, but they may be aggravating to their symptoms. So how do you reconcile that for them?
Absolutely. I think we all recognize that food is culture, right? Food
Yes.
food has so much meaning for all of us because it can bring us. It has to do with religious beliefs. It has to do with family. It has to do with our socialization. It has to do with where we grew up. But not only that, it also has to do with affordability. It has to do with accessibility. So I think it is very important that, again, I go back to in medicine, there is no one size fits all. I think we have to see every person as a unique individual and see it with curiosity. I always try to ask my patients before I provide any type of dietary recommendation of handout. I always say, tell me about what you like to eat. Tell me what are your usual meals you have at home and share a little bit more about what did you eat yesterday? Tell me what do you eat a classic day? And I think once we start engaging with them, being able to learn about what they like to eat, what are the challenges they have to with diet, then I think I can shape the dietary recommendations I have according to this patient. Because I think that's the way we build a rapport, a trust, when we really care and we are adapting our recommendations to their environment, to who they are as a person, as a whole individual. So I always like to do that. I first like to ask, and based upon that, adapt these diets to what is important for them. And we try to work together. An example is beans, right? Beans in the Latino culture, they are essential.
Yes.
Somebody will think, how am I going to be without beans? And we can start discussing alternatives, right? Do you think lentils will be a good alternative for you? And a lot of patients will find good alternatives. And also, it's a way not to limit as much their diet, because what about if the things we are recommending are what they are mostly eat at their food? Or also, as I mentioned, how much can they afford or have
Right.
access to what we are
Right.
recommending?
Yeah, absolutely. That's a great point. I
Yeah.
think, two, we don't consider affordability enough, I think. And when we're making
Mhm.
dietary recommendations, so much of even the low FODMAP diet, kind of safe foods can be quite expensive for
Right.
patients
Yeah.
on limited incomes. And I think that food insecurity is a growing issue in the United States, and we really need to be asking some of those questions before we're working in dietary therapy recommendations. So your point is well taken. On that same note, I'm curious for both of you, Andrea and Rosie, you know, when we're talking about remedies that may be more traditional to certain cultures, that may be contraindicated or lack scientific evidence for their use. And I'm thinking about, I have a sister who deeply, strongly believes in certain traditional remedies, kind of wives' tales kind of things, supplements and essential oils and things like that to treat chronic illness where there is limited to no data to support their efficacy. But it's deeply ingrained in who she is and her religious culture. So how do you have those sensitive conversations?
Yeah, I think that is a really that's an excellent question because I think this is coming up more and more for me personally. And I'm sure for you as well, Rosie. But I try to be very honest with people about what I do know and what I don't. And, there may be certain therapies out there that are, more kind of exploratory, or there just isn't enough data regarding their use specifically for the disorders that we're seeing. And I'm very upfront about that. But I do also try to make sure that I don't feel that I do my best to make sure that people don't feel dismissed when they bring up these therapies, because the last thing I want to do is to make them feel alienated, or to make them feel that I'm, passing any sort of judgment on their approach, because you're really shaped by your environment and the people that have been around you and the different influences and information that you've been given. And people are just trying to do their best. And I'll initially frame it like, I'm glad that you asked me, and I'm glad that, you're seeking some medical information or guidance in this. So I tell them honestly when I think that something is not well vetted. If it's something that they've found useful for them, but I know that it's relatively safe, I will, express it in that way. Like, I have no concern with you continuing the therapy. I don't know if it will help you or not, but, in this scenario, I think it's totally harmless to continue if you have some benefit. But in spaces where I'm not sure if there could be potential risk or versus harm, then I explain that to them as well. At the amounts that you're taking or the duration, maybe these are things that we have to be more careful about. But again, that discussion is very individual depending on the person. But Rosie, I'm sure, I don't know. How do you approach that?
No, Andrea, I agree very much with you. It's a very important topic. And also, I think I approach it very similar. I think, first of all, I try to show that I'm very respectful about it and that I'm very curious about it. So I ask, but I'm also very intentional. I'm very intentional with every single patient. Even though I have nurses who help me to get all the medication list, I'm very intentional to ask them about what else do you take at home? Do you take any herbal remedies? Did you take any teas? Have you tried? Did you do any complementary therapies? Anything else? I'm very intentional to learn about it. Then I ask them, how did you find out about it? How are you feeling since then? And I think I showed that I'm very respectful to their beliefs and traditions, but I also wanna be sure that they are safe, as Andrea mentioned. So if I feel that there is any possible harm, I will let them know about it. And I also try to see whether sometimes I have patients who bring me 10 herbal supplements or more remedies. And I try to be very honest about saying, if you are in 10 herbal remedies, the chances that you are having a GI side effects are very high. And I'm not just saying it, but there has been studies that show that. Would you like to explore more? And I'm very lucky that in my institution, we have internal medicine doctors who specializes on complementary and alternative medicine. And I'm able to refer these patients. And what they help me with is they make a review of all these supplements and they see whether there's any interaction, any possible concern based upon the medical history. So I think, again, if I'm not an expert, I'm very honest about it, but I'm very fortunate that in my institution, I have integrated medicine that can help us to deal with that.
That's great. I appreciate that you both mentioned that you stay curious and you try to be as non-judgmental as possible. I think staying out of judgment is so important when communicating with patients who are just trying to find something most of the time. They're just trying to search for something that might work before they get to see you. And it's hard many times to stay out of judgment when you're having these conversations. But I think that's a really important piece to emphasize because patients none of us like to be judged or feel judged for the decisions that we're making, particularly when we think we're making the right ones for us. So
Right.
having those safe conversations, I think, is really, really key. So I appreciate you both mentioning that. I'd like to move on to the idea we've talked before, Andrea and I, on previous episodes about the stigma that exists around IBS and the stigma that patients feel with this diagnosis, maybe even feel from healthcare providers. How do you handle cultural stigma around this condition? I have a friend that comes from an East Indian background, and for her, cultural stigma around GI disorders is a very heavy burden that she bears. And so she can't really have conversations with her family. Her husband, even, that's a conversation that is shunned and not discussed. So how do you handle stigma culturally around this condition? It's a tough topic, I'm telling you.
Yeah.
Yeah.
Rosie, I'll let you go first.
I think, thank you, Andrea. Thank you. I think it's a very difficult topic because per se, IBS has already a lot of stigma, and
Yes.
actually any disorder of gut-brain interaction has a lot of stigma
Yes.
already. So if we think about it, we are having a patient that it is suffering from discomfort, from pain, from having to constipation. But not only that, she's suffering because she doesn't understand very well what is happening. She doesn't understand what are the consequences of this disease. She doesn't understand exactly what is a good treatment. And then she has to deal with an environment in which irritable bowel syndrome, unfortunately, has this connotation that is related to their mind, to stress, that is all provoked. And there is kind of a sense of guiltiness in a lot of patients. They
Absolutely.
feel guilty, they feel ashamed, they feel like, am I a weak person, right? Because can I not control my emotion? And it's so terrible that they are not only suffering from the disease, but they are also suffering from all this stigma in our society, and especially in certain cultural backgrounds, and different backgrounds, like certain cultures, IBS in general is looked by weakness, or if there's an associated or a comorbidity or a mental disorder, it's even worse. It's even worse just to talk about it. Also by gender. In many societies, men don't feel pain. Men do not complain. Men do not go to the doctor unless they have something very serious.
Right.
And the disorders of gut-brain interaction are not thought to be very serious, even though the symptoms can be so severe and so disabling and really affect the quality of life tremendously. There's people who still don't go to seek care because the stigma of their backgrounds.
Absolutely. Yes.
Yeah. Yeah, I think it's definitely a challenging scenario because obviously once they leave your office, they, go back to their day to day and they still have to navigate that with their
Right.
symptoms. I think probably the first thing that we can do is, first of all, acknowledge how this impacts their relationships and how it might be perceived around the people around them, and just offer the ability to have that conversation with you as a provider.
Right.
I like, for example, even from a very simple distinction of men and women. If men do come and seek care, I kind of take that as, well, they at least have taken a first step to maybe kind of break the expectation or the boundary, and so that is a clue that they're kind of going against the expected
Right.
behavior, and I'm
Yeah,
encouraged by that.
for
And
sure.
we sometimes just having that conversation, just acknowledging, hey, it's hard for them to talk about this with their family or people at work, and people don't understand. And we might not be able to solve those problems, but I
Absolutely.
think just the fact that they realize that we we understand that and we see that's a part of their experience, I think that can sometimes be very therapeutic in itself as well.
Yeah, I agree with you. I think additionally, there are becoming some really great patient advocacy groups that are starting to form around different backgrounds and cultures that can help provide education and support for these patients. I know my friend Tina runs a beautiful one for, you know, South Asian and Indian patients with GI conditions, and they're really able to provide some support and empowerment for patients, and then some education for their loved ones, so that they can maybe break some of these cultural stigmas that have existed for a long time that have been very detrimental to patients physically and emotionally. So I think the more we can do to support that is also helpful. This kind of leads into this new topic that I want to get into with you guys. I'm super excited about because Rosie already kind of, before we started recording, she kind of previewed how she handles, but shared decision making. We talk about it all the time. We talked about it in previous episodes and how important it is, and the outcomes for patients, and in that patient provider relationship to share the decision making. But that can look very different based upon a patient's background or their cultural expectations of what that is going to be. So Rosie, I'd love for you to kind of discuss how you handle shared decision making with patients from different cultural backgrounds.
Yes, absolutely. We were just talking about it, but about how important is this? Because in my practice, I get patients from all different backgrounds. And while I have some patients that what we do is they bring me all what they have researched, and I kind of even give them some studies, and we analyze the studies together, and I tell
I
them where
love
they
it.
can research. And I actually tell them, where did you read that? Let's read it together online and see what you're coming from. And there are patients who we make the decision together. And even though they go home and I tell them, why don't you read about this more? I'll give you some good, safe online resources. You can read about it. However, I have other patients where, based upon their background, they are more used to a paternalistic approach where
Right.
telling them what do you want to do will really get them very very uncomfortable, because they
Yes.
have grown up with the idea that the physician will tell them what they have to do and they will follow the instruction. And there are
Right.
patients where I always ask, what do you think? How should we manage? What is the next step? And in some patients, they do that. In some other patients, I may be a little bit more directive on what is the next step in their care. But there's also a very important influence that is family. And in many cultures, like for example in Latinos, family plays a major role, and they are seen as a unit, right? Most of the time, houses are multi-generational. There's
Sure.
different grandparents, parents, as kids, grandkids live together, but they also make decisions together. So, and a lot of times elderlies will rely on their grown-up children. Children may, or young adults may go back to their parents to make decisions together. And in these patients, a lot of times what I try to do is there is no rush. So what I say is I give them the options of next step in their care, and I say, you don't have to make a decision today. Why don't you go back home, talk to your family in a comfortable environment, explain them what we talk. I always be sure that I was able to communicate and they understand what I attempt to communicate by them telling me back what is the plan or what are the options. And then I say, go and talk to your family. You don't have to make a decision right now. If any of your family members have any questions, they can always reach back to me. And then you reach back to me later and let me know what you have decided. Because I want to respect and understand the importance for their family to be included in this decision and how these patients will feel more encouraged and motivated if the family is supportive of the next step in their care plan.
Yeah, absolutely. And then that leads to better adherence to the treatment
Absolutely.
plan as well, for sure. I think
Absolutely.
it's
Yeah.
so interesting that I think in all of these situations that we've discussed, it could be so easy, again, to go back into that judgmental mode with what do you mean you have to talk about it with your family? What do you mean your children need to weigh in on the decision of your treatment? Like for many of us, that's kind of a strange decision making process. But I think I love the fact that you don't rush. You let them, you let them make the decision in their own time and what makes sense for them and go home and discuss it and come back. I think that is just a beautiful way of handling shared decision making in these situations.
Thank you, Johanna. And I think I always think me as a clinician, I should not only be treating the symptom, but seeing the context of the symptoms, right? We need to not only apply evidence-based medicine, but more than that, we should apply human-centered care, right? Like we have to see this individual as a unique person. We're not treating a symptom, we're not treating a disease, we're treating a person that is suffering from this. And I think I always have to keep reminding myself because, we have busy practices, we have our time is limited, and certainly we have many stressors from different areas. But I think when we sit there with our patient, we need to see this is a center, and we want to provide human-centered care. We
Yeah.
do want to practice evidence-based medicine, but the care should be human-centered. And I think if we always remind ourselves, which can be challenging with all these things we have to deal with in a clinical encounter, but just keep that in our minds.
Yeah, that's
Yeah.
beautiful. I love that. I think the more we can remind each other of that, the better our patient outcomes will be too, right? And you really
Absolutely.
build that trust and that relationship between yourself and the patient, and they see you as a true partner in their care. So that's fantastic. Andrea, what are your thoughts on this topic and shared decision making?
I think Rosie brought up such a interesting point that shared decision making is more than just making treatment choices together, but also understanding how a patient wants to approach their care, whether it's more physician led, whether it is kind of this joint approach, and who's involved in the care, and being able to design that approach really requires that we understand our patient and who they are as a whole person, because then you can more effectively move forward. Do we kind of approach each decision as it comes? Do we lay out all the options? And all of that kind of has to be individualized to make sure it fits their comfort, their model, their ability to kind of be productive and not be overwhelmed, or perhaps also feel like they're not being underinformed. So everyone has a different preference, and being able to pick up on that requires this awareness and taking time to get to know the person sitting in front of you, and just the whole context of how they're there.
Yeah, definitely. Well, we're getting close to the end of our time, and so I want to ask both of you what I ask every episode. Andrea always goes, "Oh, I don't know. Somebody go first." So my question to both of you is, what tips would you have for providers who around this idea of being culturally competent in treating their patients? What one tip would you leave with our providers?
One tip. Oh, okay.
I
So
know it's a tough one.
it is a tough one, but I would say always have that curiosity to ask before you assume something about the patient or the ask. Be curious about your patient.
I love it. Great advice.
Yeah, I think mine would be something very similar, but to stay open minded and just to be aware of the fact that some interactions may be perceived differently from your end and their end, and just taking into account maybe this is just a culture or background that I'm not familiar with, and not making assumptions about behaviors or communication, because they can be so different and the expectations can vary.
For sure. I think the big kind of quote from this episode is going to be, you can practice evidence-based medicine and still practice human-focused medicine. And I think that's a beautiful tip to leave with our patients and our provider listeners today. So Rosie, thank you. Thank you so much for joining us. This was a really delightful conversation, and I learned so much, and certainly appreciate your passion and love for patients. So thank you very much.
Thank you very much. It has been an honor for me to be sharing this conversation with you, Johannah and Andrea. I really have enjoyed, and I think this is a very important and relevant topic. Thank you very much. It has been an honor.